Hello, you guys hear me? Hello.
Yes, sir.
Okay, perfect. So today we'll be starting our discussion on gastrophysiology. So today we are going to finish off like entire physiology. And okay, can you guys just see my screen?
Yes, sir.
Okay, perfect. So let's start our today's discussion. So the first discussion of today is going to be hormones, right? Different hormones which act on our digestive tract, which act on like different cells of our stomach, their functions. So we'll be starting with that. Okay. So you guys are going to be like telling me. I'll be asking you some questions regarding these hormones. So the first hormone which we are going to discuss is gastrin, right? So can you guys just tell me from where do the gastrin come? Like for example, let me draw the stomach. If for example, if this is your stomach, okay. So as we know that we have different parts of the stomach, the fundus, the antrum. So what do you guys think? The gastrin, the hormone gastrin is going to be like coming from which type of cells, and those cells are going to be present where within the stomach? Where exactly?
G cells.
G cells.
Okay, perfect. So gastrin basically comes from G cells, and G cells will be present where?
Antrum of stomach.
Room.
Antrum of your stomach. Perfect. So we have, and like this portion of the stomach is basically known as antrum. Within the antrum, we have like characteristic cells that are known as G cells, and the major function of G cells are to make gastrin, right? Okay. So can you guys just tell me that what regulates the release of gastrin? How do gastrin, like why the gastrin come into play? What's the function of gastrin, and what's the stimuli, or what's like the regulatory mechanisms of release of gastrin? What do you guys think? First of all, let's discuss the function of gastrin, right? So if we know the function of gastrin, then we will be knowing the action or the regulation of gastrin. Okay, so what's the function of gastrin? What do you guys think?
Stimulates the acid secretion by the parietal cells.
Perfect. So it means we have cells which are known as parietal cells. What's the function of parietal cells? Two functions. First of all, they are going to release HCl, acids, right? Okay, so gastrin basically is going to act on these parietal cells, and it's going to stimulate the release of HCl. Perfect, right? So the first function is HCl release. Okay, what do you think? What's the other function of your gastrin?
To increase mortality.
Okay, perfect. So it would increase mortality, right? Mortality of your stomach. Perfect.
Yes.
And what do you guys think? What's the last or the third function of your gastrin?
It stimulate the growth of the the stomach mucosa.
Perfect. So it would stimulate the growth of stomach mucosa. And another thing which you guys should just keep in mind, it also stimulates the release of pepsinogen, right? Pepsinogen. What is pepsinogen? Who is going to tell me that? What's the function of pepsinogen?
Is the enzyme that
Okay.
for protein,
It
Okay,
converts.
perfect.
digestion of protein.
Okay, so pepsinogen is basically going to be converted into pepsin, and pepsin further helps in, yes, what's the function?
Protein. For protein.
Okay, protein metabolism or degradation. Okay, perfect.
Yeah.
Okay,
Yes.
so this is going to be the function, the primary function of gastrin: release HCl, increase motility, increase like the mucosal layer of your stomach, and lastly, it would increase the release of pepsinogen, which is going to help metabolize our or break down our proteins, right? The enzyme. Okay, so can you guys just tell me what would be the regulatory factors which helps the release of gastrin? What things would cause the release of gastrin?
I think when there is alkalization.
Okay, that's simple. If the function of gastrin is to degrade your protein, it means whenever the protein concentration or the peptides are increased within your stomach, it's going to help release the gastrin. Can I say that?
Yes.
Okay, so the regulation, let's discuss the regulation. So whenever we have increased peptides, or like increase, if someone is consuming a lot of proteinaceous diet, so what happens? The gastrin in that case would be released more. Okay, what else? What about antral distension?
Yes.
right? If the antrum is distended, it means that we have a lot of components, food components. So it would also help to release the gastrin in order to give us more HCl in order to help our digestion. Is that right?
Yes.
Hello? Okay, what
Yes.
else? Vagal stimulation.
Vagal
We
stimulation.
already know the fact that the vagus nerve, basically, it have a lot of function. First of all, it directly acts on your parietal cell. It increases your HCl release. If you guys are aware of a Cushing reflex, if you guys remember, right? We'll be discussing that in our future modules. Okay, so what's the function of vagus? Vagus nerve also, like the parasympathetic innervation, helps in gut motility as well, right? So what's the other function of vagus? It would help release gastrin as well, right? So vagal stimulation also tends to release more gastrin when they act on your G, right? G cells. So here we can just write the vagus nerve have positive impact. It would tend to release more. Okay, what about pH?
pH is decreased.
Okay, for example, if the pH is acidic, if we have acidic pH, what do you think? What will happen to gastrin release? Would it decrease or increase?
Decrease.
Decrease. Perfect. Like if we have a lot of acid, a lot of HCl, so we already know the concept of like negative feedback mechanism, right? So simply you can think of that this increased acidity would suppress the release of gastrin in order to avoid further increased HCl. Is that clear?
Yes.
Okay, perfect. And what about somatostatin? Somatostatin effect on G cells or
Inhibit.
gastrin release.
It inhibits.
Perfect. So we already know that somatostatin basically inhibits a lot of hormones, not only your gastrin, like in your pancreas, it would inhibit both of your insulin and glucagon. In our pituitary, we already know that it would inhibit your growth hormone, if you guys remember, octreotide and that stuff from your endo, if you guys remember, right? So somatostatin would tend to decrease the release of your gastrin, right? So these were all about the gastrin. Let's discuss some high yield points. We have a syndrome which is known as Zollinger-Ellison syndrome. So what's the main hallmark of Zollinger-Ellison syndrome? ZE syndrome.
Gastric.
Hallmark of that, yes, increased gastrin release. If we have gastrinoma, like a big tumor simply of the G cells releasing a lot of gastrins, it means you'll be having a lot of acids. These acids can, give us different ulcers, and it can erode the surface of your stomach if the mucosal layer isn't present, right? So that's basically Zollinger-Ellison. The hallmark is increased gastrin. Okay, for example, if you have an individual, he's using PPI, right? He's chronically using proton pump inhibitor. Or in other words, chronically the HCl level, he tends to, he is just decreasing the HCl level by administration of proton pump inhibitors. What do you think will happen to G cells or
They will
gastrin?
Reduce.
Increase or reduce?
Just a second.
Reduce.
It's a PPI.
Just think of the negative feedback inhibition gone. Less HCl.
Oh, it should decrease then.
It should decrease or increase. If we have less
Increase.
HCl being produced due to intake of
It will be
chronic
increased.
intake
It will
PPI,
increase.
what happens? The G
Gastrin will be
cells is
increased.
going to undergo hypertrophy, right?
Okay.
Okay. What else? For example, if you have an individual, he's having atrophic gastritis. What is atrophic gastritis? The idea is really simple. If the parietal cells are knocked off due to certain inflammation, you do not have parietal cells, you have no one to make HCl. Again, the negative inhibition is gone. What will happen as a result of that to the G cells? Again, hypertrophy, right?
Yes.
Yes. So what happens? The gastrin level is going to be increased in both of these cases, right? So let me just give you a quick overview, then we'll be discussing our next hormone, right? So we have gastrin. Gastrin comes from G cells. Where are G cells located? In the antrum of your stomach. Perfect. What's the function of G cell? The gastrin is going to act on your parietal cells. It's going to release a lot of HCl. HCl in turn is going to suppress your gastrin release. Just think of a negative feedback inhibition, right? What else? It's going to increase the motility of your stomach. What else? It's going to increase pepsinogen, which is going to be converted into pepsin, which is going to degrade proteins, right? So it helps in protein digestion. Okay, so what would be the regulatory factors? Increased vagal stimulation would increase gastrin, which would further increase HCl. Is that clear? Increased peptides, again, would tend to increase gastrin in order to give us more pepsin in order to degrade proteins. Simple, right? What else? If we have antral distension, which basically is giving us the idea that we have a lot of food coming in, right? So a lot of food requires a lot of HCl, and a lot of HCl requires a lot of gastrin. That's simple, right? So what happens? G cells again would just try to make a lot of gastrin or make a lot of HCl in order to digest that food. Okay. What about somatostatin? The idea is very clear. Somatostatin inhibits hormones, right? So it would be having like inhibitory action on G cells and gastrin in turn. Okay. So ZD syndrome, increased gastrin. Chronic PPI use, what happens? You are decreasing the HCl. If the HCl is decreasing, negative feedback gone, gastrin hypertrophy. G cells hypertrophy, a lot of gastrin. What else? If you have atrophic gastritis, that is the parietal cells are knocked off due to certain inflammatory processes, which we'll be discussing. We have different type of gastritis. That is one due to H. pylori gastritis. We'll be discussing that. Okay. So what would happen as a result of that? I'll be mentioning the same point here, right? I'll be asking you guys what happened to gastrin. So gastrin would be increased in that case as well. Is that clear?
Yes, sir.
Okay, perfect. So let's discuss our next hormone, that is somatostatin, right? So all of you guys know the function of somatostatin, as we already discussed. The main function is to suppress a lot of hormones. Yes. Okay. So the first question which should just come in your mind, that from where do we have release of this somatostatin? What are the name of those cells which release somatostatin? Yes.
D cells.
T cells.
Okay, we have the cells. So we already know that somatostatin is also made within your pancreas. So it means these cells are also going to be present within the pancreatic islet, right? And in case of stomach, let me just draw the stomach structure again. So if this is your stomach, so where are these cells located? You guys are going to be telling me that.
GI mucosa. In the mucosa.
Okay, GI mucosa. Okay, which part of your stomach? Again, your antrum.
Antrum, yeah.
Right? In the antrum, you have these cells, right? Okay. So let's discuss some of the functions of somatostatin, and then we'll be discussing the regulation, right? So what are the different function, or what's the function of somatostatin? We already know it's going to inhibit gastrin. We already know that, right? What else? If it's inhibiting gastrin, it means it's also going to directly inhibit HCl as well. Keep that in mind, right?
Yeah.
It's also going to inhibit
Pepsinogen.
pepsinogen, right? Pepsinogen, perfect. What else? It's going to decrease the intestinal motility. Decrease the intestinal motility, right? Okay. Okay, if it's decreasing the gastrin, the idea is really obvious that the motility is also going to be decreased, right? Simply you can just remember it in this way, right? What about the pancreatic secretion? What do you guys think?
Decrease.
Yes, we discussed it's going to decrease the pancreatic secretions as well. Both the endocrine and exocrine secretions of your pancreas are going to be inhibited by the action of somatostatin. What else? What about gallbladder?
Decrease
What's that
gallbladder contraction.
Yes, it would decrease your gallbladder contraction, right? So these are the function, like it's the main idea is that it tends to decrease a lot of things, a lot of hormones, right? Okay, so what would be the regulatory factors which tends to release your somatostatin? What are the regulatory factors that are decreased vagal stimulation? So whenever the vagal stimulation is decreased, what happens? Yes.
Somatostatin will increase.
Yes, somatostatin will increase, okay? And whenever the duodenal, whenever within the duodenum, if you have increased acid content, right? We already know that all of the chyme is then going to be drained into your duodenum, and duodenum have a lot of mechanism in order to stabilize the acidity, like the pancreas is going to release a lot of HCO3 via the action of secretin, which we will be discussing, and in this way, it's going to help maintain or stabilize the acidity, right? But whenever the acidity within the duodenum is increased, what happens? It's going to be a stimulus for the release of somatostatin as well, right? Is that clear? So whenever within the duodenum, the acid content is increased, it's basically a stimulus for the release of somatostatin as well. And the idea is really simple. Why? Because the somatostatin in turn would try to inhibit the HCl, and in turn, like it would just tell your parietal cell to switch off. It will just switch off your gastrin activity, and in that way, it would just tend to, it would just try to, neutralize the acidic content which is coming into your duodenum. Is that clear?
Yes.
Okay, perfect, right? And we discussed that the somatostatin also like inhibits your insulin and glucagon. We already discussed that it's also going to like decrease the release of growth hormone. The drug which we discussed, octreotide, which is analog of somatostatin, which is basically given in acromegaly. We already discussed that in our endocrine section, right?
Yes.
Okay, perfect. So let's discuss our third hormone, that is cholecystokinin, right? So you guys are going to be telling me that from which cells do cholecystokinin CCK release?
Eye cells.
I
Okay,
cells of
I
duodenum and jejunum.
Eye
cells.
cells.
Perfect. Perfect. So let me draw the stomach. For example, this is your stomach. Okay, your duodenum, parts of your duodenum and your jejunum, they have basically eye cells, and eye cells basically release CCK, cholecystokinin. What are the function? Okay, what are the function of CCK? Like most of you guys are aware of that. What are the functions of CCK?
Gallbladder contraction.
Okay, perfect. It would, first of all, it would increase biliary contraction. If the biliary contraction is increased, it means it would increase the release of bile. Can I say that? Into the duodenum.
Yes. Yes.
Okay, perfect. What would it do to the sphincter?
Relaxation of
What
the
for
sphincter
sphincter?
aphodae.
Yes. Okay, so it would tend to relax the sphincter of Audi, in which basically you are going to have the, like here in the second part of duodenum, you have a sphincter of Audi, which will basically, you know, drain all of the content, the bile into your duodenum in order to help digest your lipid contents. Okay. What else? It would also increase the release of your pancreas, right? Pancreatic secretion.
Secretions. Yeah.
Right? So whenever the pancreatic secretion are increased, they are very important. We'll be discussing the pancreas in detail, what enzymes are basically. So basically, it's going to increase the overall digestion, right? Okay. Can you guys just tell me that what's the stimulus for the release of CCK?
Increase fat.
Fatty
Okay,
Increase fatty acids and
increase
amino acids. Increase
fatty
fatty acids
acids
and amino
plus
acids.
Amino acids.
amino acids. The idea is really clear. Why? Because if the function of your cholecystokinin is to release bile, it means that whenever, okay, what's the function of bile? Bile is going to, you know, like helps in
Multiple.
like breakdown of your fats, right? Converting, emulsifying your fat, converting into droplets, helping them to, you know, like helping the reabsorption. So basically, whenever we have increased fatty acid, increased fatty content, so it's going to be the stimulus for release of CCK, because CCK is going to tell the bile, the gallbladder to just release its the bile and help these fatty acid to be absorbed, okay, or to be degraded. What else? Amino acid, because as it is increasing the pancreatic secretion, which also helps in degradation of your amino acid proteinaceous content. Is that clear?
Yes.
Okay, perfect. Okay, so some of the high yield point, whenever an individual is like less hungry, okay, less hungry, then we are going to see the release of cholecystokinin. Okay, idea is very simple. If he's less hungry, it means we have a lot of content in his stomach, that is fatty acid, amino acids. So in that case, CCK is going to be increased. Is that clear?
Yes.
Okay, perfect. So let's discuss our next hormone, that is secretin, right? So can you guys just tell me the cells responsible for the release of secretin and where are they present?
S cells.
Duodenum.
Yes, sir.
The
Okay,
duodenum.
S cells, perfect. So for example, if this is our stomach, okay, so within the duodenum, we have our S cells. They're going to release secretin. What's the function of secretin? As we discussed, secretin is going to increase pancreatic HCO3, right? The bicarbonates. Why do we require bicarbonates? We already discussed. Whenever the chyme leaves the stomach into the duodenum, it's basically acidic in nature. So we have to neutralize that acid. And for neutralizing acid, we need HCO3, right? Which basically comes from your pancreas. So at that time, your secretin is going to be released by your S cells. It's going to tell your pancreas to just release HCO3 in order to neutralize the acid. Is that clear?
Yeah.
Yeah.
It would also increase the release of bile,
Bile.
right? And it will also decrease the gastric acid secretion. The gastric acid secretion, that is, it would just inhibits your, your parietal cells to produce HCl, right? The idea is very simple, because the main function is to neutralize the acidic content. So it would just do two things. It would follow two protocols for that. First of all, it's going to tell your pancreas to release HCO3, right? Bicarbs. And secondly, it's going to tell your stomach to please just make less HCl. Is that clear?
Yes.
Okay, so let's discuss some of the stimuli for the release of your secretin. So again, it's going to be your acid, as we discussed, right? Fatty acids. Fatty acids, they're also acidic in nature, right? And what else? Whenever what else? Whenever the
Okay.
bile in duodenum increases, whenever the bile content within the duodenum increases, again, it's also going to be one of stimulus for the release of your secretin. Is that clear?
Yes.
Okay, perfect. So let's discuss our next hormone, that is GIP. And you guys already know that. If you guys remembered, we discussed one of our UWorld MCQ. If we have an individual, he's taking IV glucose, one he's just consuming oral glucose. So in which set of individuals are we going to have more insulin release? Yes,
Oral,
oral. Why?
because of the GIP.
GIP, perfect. So GIP are also they're also known as glucose dependent insulinotropic peptides, right? Glucose dependent insulinotropic peptides. As the name indicates, glucose dependent. Once the glucose, they are dependent on glucose. Once the glucose come, insulinotropic. What's the tropic effect? Turning on effect. It would turn on the release of insulin. Glucose dependent. Once they come in contact with glucose, simply it has tropic effect on your insulin. So glucose dependent insulinotropic peptides. They're peptides in nature, right? So that's why if we have an individual who is consuming oral glucose, while other individual in which we are just in whom we are just administering IV glucose, so those who are consuming oral glucose, they'll be having more insulin release due to GIP. GIP are also known as gastric inhibitory peptides, right? So two names used for that: glucose dependent insulinotropic peptides or gastric inhibitory peptides, right? So why do we use the other name gastric inhibitory peptide? Because it's also going to, yes, inhibit HCl release. What's the function? Inhibition of HCl.
HCl.
What else? It would increase insulin
Insulin
release, right?
release, yes.
Yeah, increase insulin release, as we discussed. Okay, so what would be the stimuli for the release of your, okay, basically that comes from the K cell, right? And K cells are present within the duodenum and jejunum, remember, right? So they are going to be coming from K cells. Where are they present? Duodenum
Jejunum.
and jejunum, okay? Okay, so the function, as we discussed, is going to decrease the HCl release, increase insulin release, right? So what are going to be the regulation or the stimuli, as we discussed? Oral glucose, okay, the stimuli, right? For the release of your GIP, first of all, it's going to be oral glucose, as we already discussed in detail. What else? Fatty
Increase fatty acids and amino acids.
acid and amino acid. Whenever the fatty acid and amino acid concentration increases within the duodenum, it's going to trigger the release of GIP. Okay, so as we discussed the high yield point as well, you got MCQ in your endocrine section. So let's move to our next hormone, right? That is VIP. So you guys are going to be telling me, what is VIP?
Vasoactive intestinal polypeptide.
Perfect. So it's vasoactive intestinal peptides, right? Okay, so from where do they come? They comes from neuroendocrine cells, which are basically present beneath the mucosa within your duodenum, basically, right? Okay, so what are the function or the actions of VIP? You guys are going to be telling me that. That's very simple.
Increase vagal stimulation and distension.
Okay, so first of all, it's going to increase. Okay, if the vagal stimulation is increased, can I say it would increase the intestinal motility?
Yes.
Intestinal motility.
Intestinal motility is increase intestinal motility. What else? Okay, what would it do to the lower esophageal sphincter? Would it
Relax it.
Relaxation of the
relaxation of your lower esophageal sphincter. Okay, if the motility is increased, simply you can think of what's the effect on water and electrolyte. It would increase the water and electrolyte, right? As we know that
Secretion.
simply you can imagine in diarrhea what happens sometimes it's due to increased motility, right? And increased motility basically increases your electrolyte and like water, right? That's why, like for example, if you have an individual having VIPoma, a lot of VIP, so what would be the classical presentation of that? Watery diarrhea, right?
Yes.
Yes.
Okay, watery diarrhea. What else? Hypokalemia. Why are we going to see hypokalemia?
Because of secretion.
Diarrhea, like the volume that we're losing.
Yes. So if the volume is losing, what happened to effective circulatory volume? Decreases. What happened to aldosterone? Increases. What would
Increase.
aldosterone further do to K plus? It would excrete K plus, giving us hypokalemia, right?
Yeah.
Okay, perfect. So what are the stimulus which causes the release of VIP?
Increased distension.
Okay,
The vagal
increased.
stimulation.
Okay, vagal stimulation. What would adrenergic stimulation do to release of VIP? The vagal increases. If the vagal stimulation or the acetylcholine increases the release of VIP. So my question is, if you are just increasing the adrenergic stimulation, so what
Decreases the
would happen?
adrenergic
It
input.
will
Yeah.
decrease this.
Decrease. So with increase adrenergic stimulus, decrease VIP. Simple as that. Is that clear?
Yes.
Okay. So let's discuss one of our last hormone, that is mortelin, right? Mortelin. Okay. So you guys are going to be telling me first of all the cells which release mortelin, where are they present? What are the name of those cells?
In the small intestine.
Okay. So we have more cells, right? Where are they present? They are present within the duodenum
Small.
and jejunum, right?
Duodenum and jejunum.
Once the mortelin is released, what's the function of mortelin?
Its
It will
function
increase the
produces
motility,
the
To clean the small intestine for the preparation of the next meal.
Perfect. So can I say it would increase
Reduce
the
during
motility,
fasting.
increase the migration, the migrating motor complexes, increase
During
MMC,
fasting.
increasing motility, right? So it
Movement.
would increase, yes, increase the movement, right? Or increase migratory motor complexes, right? Okay. So one of the thing which you guys should just keep in mind, we have a UWorld MCQs on that as well. If you guys remember, we have an individual. Let's suppose he will we due to certain reason, if his vagal nerve is cut off, right? And he's having a condition gastroparesis. So what is gastroparesis? You guys already know that, right? If the stomach is paralyzed, let's suppose, for example, if the innervation is gone, the vagal innervation is gone. So you guys are going to be telling me which antibiotic is going to help me.
erythromycin. Yeah.
Hmm,
Thomas.
Erythromycin.
erythromycin. Why?
Fine. In receptors.
Like,
Because in advanced diabetes, the vagal nerves are destroyed
Mhm.
and they stasis of the food inside the stomach to decrease the
Yeah.
infection. Yeah.
So yes, so if yes, you have a UWorld MCQ that if an individual is having okay, so due to advanced as you just told us,
Uncontrolled
diabetes,
diabetes.
yes,
Yeah.
uncontrolled diabetes, we are going to have gastroparesis, right, due to effect of autonomic nervous system involvement, right? So in that case, we are going to give erythromycin. Why? Because erythromycin also stimulates your MO receptors.
Yeah.
Yeah. It
Stimulates.
acts on MO receptors as well. This is your take home high yield point. Just keep that in mind, right? So with this, we have almost covered a lot of hormones. So let's discuss our gastrointestinal secretions, right?
Can you
Okay.
repeat the last hormone? MO.
Okay. So we discussed we have a hormone that is basically mortelin, right? So mortelin basically comes from MO cells. MO cells are basically present within the duodenum and your jejunum, right? What's the function of mortelin? It would increase the overall motility. Simply, you can just keep in mind by increasing the migrating motor complexes, MMC, right? Okay. So the thing which we discussed, the question which we discussed, that for example, if we have an individual, he have advanced diabetes, and as a result of that, we have involvement of autonomic nervous system. And let's suppose, like for example, if this is his stomach and his parasympathetic vagal supply is gone. The vagal supply is gone. It means that now the stomach become paralyzed, right? Hello?
Yes,
Yes.
yeah.
Let
Yes.
me just name it gastroparesis, right? Stomach becoming
Alright.
paralyzed. So for the paralyzed stomach, which, like for example, which antibiotic can I give in order to, like, take two advantages? Like first of all, having an advantage that it can just remove the bacteria, for example, because as we have paralyzed stomach, there is increased chances of getting bacterial infection there, and we can also use the other aspect of this drug, that it's going to stimulate the MO receptor, increasing mortalin, which will further increase the motility of stomach. So in this way, we can help compensate the gastroparesis. Is that clear?
Alright.
Okay, perfect. So let's discuss our next topic, that is gastrointestinal secretion, right? So you guys are going to be telling me that that's a very simple topic, that is GI, okay, gastrointestinal secretion. So we'll be starting from stomach, right? So in the stomach, as you guys remember, we have characteristic cells, parietal cells. So what are the function of parietal cells? You guys are going to be telling me that. Parietal cells.
It secrete the hydrochloride.
Okay, HCl. What else?
Intrinsic factor.
Perfect. Intrinsic factor. As we discussed that, for example, if we just ingest vitamin B12, so in the mouth, it's going to be banded with a certain factor. What's the name of that? We discussed that, right? In a big detail.
Yes.
R.
Vitamin
R.
R binder, right?
Yes.
Okay, yes. B12 is going to be binded with R binder. Once it just come down, your pancreatic protease is going to release, it's going to remove the R binder, if you guys remember. And then intrinsic factor, which basically comes from your parietal cells, are going to be binding with your B12. And why do we need binding of B12 with intrinsic factor? Yes.
By the it is required for the B12 uptake in that ileum.
Perfect. So in the ileum, if we
Vitamin
want,
B12. Yeah.
yes. So for the reabsorption of vitamin B12, we need intrinsic factor to be there, right? So without intrinsic factor, our ileum cannot absorb vitamin B12. Is it clear? Okay, so it means that the intrinsic factor comes from your parietal cells. If you guys remember pernicious anemia, what happens? Macrocytic anemia and the entire story, if you guys remember. No B12, no DNA, proper formation, big cells. Did you guys remember that story which we made?
Yes.
Yes.
Okay, perfect, right? Okay. So the next function of your parietal cell is to release HCl. Okay, so you guys are going to be telling me, like we already discussed. For the release of HCl, parietal cells basically have three receptors, right? 1, 2, and 3. Or 3 stimuli for the release of HCl. So you guys are going to be telling me that. What's the first one?
Gastrin.
Gastrin. Perfect. What's the second one?
Vagus nerve. Vagal.
Acetylcholine, right? Or the vagal stimulation.
Vagal stimulation.
What's the third one?
Histamine.
Histamine. From where do the histamine come? ECL cells, remember? Enterochromaffin cells, right? Like gastrin is also going to increase the activity of ECL, which in turn is going to increase the histamine release, right? So gastrin can either directly stimulate the release of HCl, and it can also indirectly, stimulate the release of HCl by stimulating your ECL cells. That is enterochromaffin-like cells, right? And once they stimulate these cells, they're going to release histamine. Histamine have a proper receptor on the parietal cells, which is then going to help them, make more HCl. Is that clear?
Yes.
Okay, perfect. So histamine, vagal stimulation, and gastrin. What are the inhibitory stimulus for the release of HCl?
Prostaglandin.
Okay, yes, prostaglandins. What else?
Somatostatin.
Yes, somatostatin, as we discussed. Somatostatin inhibits your gastrin, and gastrin in turn inhibits your HCl, right? That's simple.
Yes.
Okay, what about GIP?
Yes. Also inhibit.
Discuss GIP, gastric inhibitory peptide. It would inhibit the release of HCl, as we already discussed, right? Okay,
Yes.
so the next kind of cells which are basically present, the next type of cells which we'll be discussing, which are present in your stomach, are your chief cells. Chief cells. So what are the function of chief cells?
To increase pepsin.
Then release the pepsin.
Okay, perfect. So it would basically release pepsinogen, which is a zymogen. So what is zymogen? You guys are going to be telling me that. What's
Inactive form.
okay? So it means that pepsinogen is going to be a zymogen. Zymogen means that like pepsinogen further is going to be cleaved into pepsin in order to be, getting a functional enzyme pepsin, right? And what's the function of pepsin?
For protein digestion. To
Yes,
cleave the protein.
again, protein digestion. Okay, perfect. So these, okay, and what about mucosal cells? As we know that mucosa is protective to your stomach in two ways. First of all, it's going to be a physical barrier. Secondly, it's going to be releasing bicarbonate, which is going to neutralize the acid. Help it won't allow the HCl to eat your digest your own stomach, right? So it's going to be helpful in that way, right?
Yes.
Okay, the mucus itself is basic in nature. Okay, so just give me 2 minutes. Let's have like 2 to 3 minutes of break, and I'll be coming back in a while. Okay,
Okay.
thank you. Hello.
Yes.
Okay.
Yeah.
So let's discuss our next topic, that is going to be our bile, right? Bile. So we'll be discussing the entire circulation of our bile. What are the intermediate things which are going to be made? What's the function of bile? We'll be discussing in detail, right? So first of all, you guys are going to be telling me which organ produces your bile. That's a simple question.
Gallbladder.
I think it's stored in it gets stored in gallbladder. It's produced by your liver, right? Yes. So liver basically produces your bile, and bile in turn is stored within the gallbladder, right? Gallbladder.
Yes.
Okay. How do the bile is produced in the first place, right? So we know that, for example, if we have cholesterol, so cholesterol is going to be acted by an enzyme. What's the name of that enzyme? Cholesterol 7-alpha hydroxylase, right? Cholesterol 7-alpha hydroxylase. What happens next once this enzyme is acted? The cholesterol is going to be converted into bile acid, right? Is that clear? Hello?
Yes, sir.
Okay. So cholesterol, an enzyme cholesterol 7-hydroxylase is going to be acting on cholesterol. It's going to be converting cholesterol into bile acid. Can you guys just tell me, can we dissolve bile acid like in water? Is it hydrophobic or hydrophilic? What do you guys think?
Hydrophobic.
Phobic, like you cannot dissolve it in water, right? So in order to be soluble in water, bile acid is going to be converted into bile salt. Salt can be, they're soluble in water, right? And we
Yes.
want bile acid to be converted into soluble state. So how do we convert acid into salts? The idea is very simple. We are going to combine it with base, right? So what bases are going to be used? That is glycine plus taurine, right? If you guys remember your chemistry lectures, how do we make salt? Just mix acid with bases, right? We get salt,
Yes.
right? Okay. So these acids are going to be mixed with certain bases. What are those bases? Glycine and taurine. So once we just mix these acid and base, we are going to be having a salt. That is basically bile salt, right? Bile
Yes.
salts. Okay. Well, okay, so now the bile salts are water soluble, right? They are water soluble. Is that clear? Okay. So what's the function of bile salt further? Bile salts can bind phospholipids. They can bind phospholipids. They can also bind cholesterol as well. And simply you can imagine, right? You can simply think, as the bile salts are made of cholesterol, right? So can I say that the bile salt would be having certain components having cholesterol? Can I say that?
Yes.
Yes.
Okay. So for example, if you have salts having cholesterol, so like dissolve like. If you guys again remember your chemistry lectures, right? Like dissolve like, right? What do I mean by like dissolve like? Cholesterol will dissolve cholesterol, right? So it means that bile acid would, what would it do? It would bind, it would be having a lot of affinity towards lipids and cholesterol. Is that clear? Hello?
Bile salt is high affinity, right?
Yes, it have high affinity. It would just bind with phospholipid and cholesterol. What else? It can also bind with bilirubin, right? We'll be discussing bilirubin in detail. What are bilirubin? What are different types of bilirubin? And they are basically excreted from our body in your bile, right? You already know that. The color of bile is basically due to bilirubin. Is that clear?
Can you
Yes.
kindly repeat this point?
Okay. Okay. So as we discussed, we have bile salts. The bile salts basically have the cholesterol content, right? So it means that they are going to dissolve, they are going to bind, they can bind with cholesterol. They can bind with phospholipids, right? And the bilirubin, which we'll be discussing, what is bilirubin? You guys know whenever the heme is broken down to bilirubin. Bilirubin is then released into your bile for the excretion, right? And the color of bile is due to bilirubin. You guys know that, right?
Yes.
Yes.
Okay, so it means that bile can bind phospholipid, it can bind cholesterol, they can bind bilirubin, right? What else? As we discussed, they are water soluble. It means it can also be soluble, or they have affinity. It can, the molecules can bind with water plus iron as well. Is that clear?
Yes, sir.
Yes.
Okay, perfect, right? And as we discussed that these bile salts are going to be stored within your gallbladder, right?
Yes.
Different hormones contract. Okay, which hormone would contract your gallbladder? We discussed CCK, right?
Yeah.
CCK.
Yeah. So, for example, if we need, like if you have a lot of lipid content within your duodenum, what happens? CCK is going to be released. CCK in turn would contract the gallbladder. Gallbladder is going to release your the content, the bile acids, and what would it do? Okay, so what's the function? The function of your bile is basically digestion and absorption of lipids, right? Lipids. Is that clear? So it is going to help digest and absorb lipids. Is that clear?
Yes.
The idea is really simple because it can bind the lipid content. So what would it do? For example, if you have a big molecule of lipid, so all the bile acids are going to come, it's going to bind to look like the lipids, and in turn it's going to break this big molecule into small droplets of lipids, right? So in this way, it's going to help digest lipids. Is that clear?
Yes.
Okay. Another point which you guys have to keep in your mind, whenever we have less bile, in that situation, your calcium is going to bind to fat, right? Or I can say that the bile prevent calcium to bind to your fats. Let me just write it down clearly, right? Your bile basically prevents the calcium to bind with the fats. The idea is very simple. Why? Because bile is just, it's helping break down in the breakdown of your lipids, so it do not give enough space to the calcium to be attached to your lipids, right? Okay, what if the lipids attach or the fats get attached to calcium? What would happen as a result of that? Yes, what do you guys think?
Saponification of the fat.
Okay, yes, you can have saponification.
Saponification, yeah.
Okay, what else?
Maybe
Uh,
kidney
Whenever
stone.
calcium binds to fat, it also increase free oxalate reabsorption. Free oxalate, right? So the oxalate also increases whenever you have your fat, it's attached to calcium. So this complex is also going to attract oxalate, right? And if the oxalate is attracted, it's present in the blood. If you have a lot of oxalate, you guys know from the renal section, it would increase calcium oxalate stones, right?
Yes.
Hello? Like for example, we have a disease, Crohn's disease. In the Crohn's disease, what happens? For example, if the distal ileum, okay, so all of the bile acid basically get reabsorbed in the distal ileum, right? If you have inflammation in the ileum, simple, right? Okay, so one of the point which we'll be discussing in Crohn's disease, let me just make it clear here, right? So for example, in the Crohn's disease, if you have inflammation of ileum, right? And as a result of that, what happens? Bile cannot be reabsorbed, right?
Yes.
Okay, if the bile cannot be reabsorbed, can I say that bile is going to be less? If the bile is less, now what happens? Now free calcium would bind to fat. Can I say that?
Yes.
If the free calcium bind to fat, now oxalate is also going to be reabsorbed more, and oxalate is reabsorbed more, so it would, it would tend, this individual is going to be prone to have calcium oxalate stone. So can I say that Crohn's disease, in an individual with Crohn's disease, is most likely going to have kidney stones, that is calcium oxalate stones? Can I say that?
Yes. Yeah.
Okay.
Yeah.
Okay. Perfect. Right. So this was all about bile. Let's discuss our next topic, that is bilirubin. Right. Bilirubin. So as we know that, for example, if we have like worn out red blood cells or senescent red blood cells, so red blood cells basically, like the macrophages are going to come, they're going to degrade different component of your red blood cell, one of which is hemoglobin. Once the macrophages degrade your hemoglobin, the heme and the globin is going to be broken down into amino acid, reabsorbed by your body. What about heme? Iron content is going to be,
Broken
detached,
into
again it's
iron
going to be
and
reabsorbed for the
protoporphyrin.
future use. While the heme further, yes, protoporphyrin, right? But the protoporphyrin further are going to be converted into biliverdin, and like the heme into biliverdin and unconjugated.
Bilirubin.
What do we mean by unconjugated bilirubin? Yes.
It cannot be absorbed.
Not water
Yes.
soluble.
They aren't water soluble. They cannot be solubilized in water. They are not water soluble. In order to be solubilized within the water, right? In order to in order to convert them into soluble substances, we must conjugate it, right? So for example, let's suppose if this is our blood cell, we have some. Okay, we also call it as indirect bilirubin, right?
Yes.
Indirect bilirubin. So what happens? Your albumin is going to come. It's going to take indirect bilirubin into your liver. Here we have an enzyme. What's the name of that? UDP, glucuronoside transferase, right? So this enzyme is going to convert it into direct bilirubin, right? And direct bilirubin is water soluble, right?
Yes.
That bilirubin is going to be released into bile, as we discussed,
Yes.
right? Once released in the bile, it would just come into your intestine, and your gut bacteria is going to be converting this direct bilirubin into
Urobilinogen.
urobilinogen. Urobilinogen further is going to be converted into reduced form, right? Like if it is getting more reduced, it's going to be converted into stercobilin, and less reduced form is urobilin. So the stercobilin is going to be, released in the feces, and the brown color of the feces is basically due to stercobilin. Is that clear? Why?
Yes.
The urobilin can be reabsorbed in your blood, and it can be excreted like in the urine, giving the yellow color of urine, right?
Yes.
Is that clear? Let me just repeat this cycle again. We have hemoglobin, right? Heme is going to be converted into indirect bilirubin, right? First of all, biliverdin and indirect bilirubin. Your albumin is going to take this indirect bilirubin into your liver. There you have an enzyme that is UDP, glucuronoside transferase. It's going to be converted into direct bilirubin. What's the need of direct bilirubin? Direct bilirubin is basically water soluble, right? So direct bilirubin is going to be released into bile. And once this bilirubin come in contact with your gut bacterial flora, it's going to be converting into urobilinogen. Urobilinogen into more reduced form, stercobilin, giving brown color of feces. Less reduced form, urobilin, giving yellow color of urine. Is that clear?
Yes.
Okay, perfect, right? Okay, so what are the clinical things which we'll be discussing in our pathology section? But here you guys should know that, right? So I'll be asking you some questions. You guys are going to be answering that, right? Okay, we have an individual. We have biliary obstruction. So first of all, you guys are going to be telling me, he have biliary obstruction. What do you guys think? The bilirubin in that case would be direct or indirect in the blood? For example, if the bilirubin leaks into the blood, what are you expecting? Would the bilirubin be in the direct form or indirect form? Conjugated or
Indirect.
unconjugated?
Conjugate.
Indirect.
Yes, direct.
Dr.
The,
Margaret?
the liver,
Right.
the liver is working, so it's conjugating bilirubin. So there is no
Yeah.
problem with the liver. It's just that there is
Yeah.
obstruction, so that's why. Yeah.
Perfect.
Yes, first
Oh,
it obstruction to the liver, and the liver is going to conjugate the bilirubin.
yeah.
Yeah.
Obstruction is
So
The
distal.
liver
as we do not
conjugate.
have any problem with the liver
Oh,
can
yes.
still conjugate it. So we have conjugated or direct bilirubin, but we have some obstruction. It means this obstruction. Okay, what happens if the direct bilirubin is keeping on accumulating within the gallbladder? It's going to be leaked into your it's going to be leaked in the blood, and it's going to deposit it in different structure. For example, it's going to give the scleral icterus, the yellow discoloration of your sclera, the pale skin, right? And as we discussed, can you guys just tell me is the direct bilirubin can you just tell me, can it appear in urine? Yes or no?
Yes.
I think no.
No. In the urine, we are only
No.
going to see urobilin.
No. No.
Urobilin only appears in urine, right? So still we are going to have dark urine, right? Dark urine, pale feces, because still the conjugated bilirubin must be converted into urobilinogen and stercobilin in order to give brown color. So still the feces are going to be pale, the urine is going to be dark, but the skin is going to be like yellow, right?
Yes.
Okay, for example, let me just give you another scenario. We have an individual, he have hemolysis, a lot of red blood cells being breaking down. Which kind of bilirubin are you expecting in the blood? Direct or indirect?
Conjugate bilirubin.
Oh,
Unconjugated. Okay.
Yes.
Perfect. So we'll be seeing unconjugated hyperbilirubinemia, right? And similarly, if you have an individual with cirrhosis or hepatitis, then which kind of
Unconjugated.
yes?
Because the liver is
Unconjugated.
bilirubin.
Both conjugated and unconjugated. Remember, right? Both
Both.
conjugated and unconjugated, because in this
Unconjugated.
case, yes, if you have liver cirrhosis or hepatitis, so some of the cells, as you know, there are it's some problem related within your liver. So some of the cells can lose the ability to conjugate your bilirubin, and some of them will be functional, right? So you'll be having both conjugated and unconjugated bilirubin, right? We'll be discussing that in detail in our hepatitis module in our pathology section. Don't be worried. Okay. So let's discuss intestinal absorption, right? So we have some small topics remaining, and then we have finished our okay. Let's discuss some of the function of exocrine pancreas. So you guys are going to be telling me, right? The enzymes released by your pancreas, right? Yes, pancreatic enzymes.
Yeah, insulin and glucagon.
Okay, exocrine, not endocrine.
Amylase, lipase, and
Okay.
Proteases,
Okay.
trypsin.
I just
trypsinogen.
Okay, first of all, let's discuss which hormones do help in the release of these enzymes, as we discussed already.
CCK.
Perfect.
Pepsin.
And secretin as well, right?
Yeah.
Okay. What are the enzymes? Lipase. What's the function of lipase? Everyone knows that. Lipid
Fatty
digestion,
acid.
right? Degradation of your triglycerides, cholesterol, ester, phospholipids, right? Proteases.
Protein
That is
metabolism. Digestion.
protein digestion. Okay, with proteases, okay, all of the proteases again are going to be in a form of zymogens, right? They are going to be proenzymes, like they are going to be cleaved and then they are going to be converted into proper functioning enzymes, right? So we have trypsinogen, which is going to be converted into trypsin, like we have trypsinogen, a zymogen, which is going to be converted into trypsin. We have chymotrypsin, right? And chymotrypsin is going to be like chymotrypsinogen, which is going to be converted into chymotrypsin, trypsin. We have pro-elastase, which is going to be converted into elastase. We have pro-carboxypeptidase, which is going to be converted into carboxypeptidase, right? So the function of all of these enzymes, for example, your lipase is going to degrade your lipids, your proteases, all of them are proteases, like your trypsin, chymotrypsin, elastase, and carboxypeptidase, right? And your alpha amylase, which is going to break your carbohydrates, but amylase isn't a zymogen. Alpha amylase is a simply, you can imagine it's a more mature kind of enzyme which can directly act. It isn't a zymogen, right? Alpha amylase. Is that clear?
Yes.
It isn't a zymogen. Okay. So let's discuss our next topic, that is intestinal absorption. How do your intestine absorb different kind of nutrients, right? So let's start with protein absorption. Right? So as we discussed that the proteins can be in a form of amino acid, the smaller building blocks, amino acids. That can be in a form of dipeptide chain or tripeptides chain, right? So how do the absorption of amino acid, dipeptides, and tripeptides take place? Do you guys have any idea? Like, for example, if this is our enterocyte, right? So how do the amino acid get reabsorbed or absorbed? How do the dipeptidase and tripeptidase or tripeptides or dipeptides get absorbed? Do you guys have any idea? Okay. So remember, we have a transporter that is a Na-mediated transporter, right? So all of your amino acid are going to be reabsorbed in the enterocyte via Na-mediated transport. Remember, sodium-mediated transport is going to help absorb your amino acid. Is that clear? While your hydrogen mediated or H plus mediated transporter is going to help reabsorb your dipeptides and tripeptides. Is that clear? Is that clear? Hello?
Yes.
Okay. Let me repeat it again.
Can you repeat this again?
Yes, let me repeat it. Amino acids are basically small building blocks of your proteins, right? So the small building blocks of proteins are going to be reabsorbed by your enterocyte. This is your enterocyte, right? Cells of your gut, right? Okay, so they are going to be reabsorbed via a transport that is Na-mediated transport, right? Or Na or the sodium reabsorption. Okay, once the Na is reabsorbed, it would help reabsorption of your amino acid. While we have another transporter which is H plus mediated transporter. So you have a transporter whenever H plus go in, along with the help of H plus, dipeptide and tripeptide are also going to go in your cell. Is that clear?
Yes.
No? Okay, then we have amino acid transporter, right? So these dipeptide and tripeptide are going to be cleaved into amino acid by an enzyme which is peptidase, right? Peptidase. So all of, like, in the end, you only have amino acids, right? Like peptidase is going to cleave them into amino acid, and you have specific transporter for the amino acid. This is present on the basolateral aspect, and it's going to enter into your blood. Simple. Is that clear? Hello?
Yes.
Okay, perfect. How does the lipids get absorbed? As we discussed, just first of all, the bile is going to be converted into small droplets, fat droplets, right? So the bile is going to be attached to those like small droplets. It's going to emulsify these droplets, converting it into more smaller structures and ultimately into triglycerides, right? Bile acids. Is that clear? Triglyceride further is going to be acted by an enzyme lipase, right? It's going to cleave it into more smaller structure fatty acids, right? Is that clear?
Yes.
Fatty acid can be of two types, long chain and short or medium chain fatty acid. Short and medium chain fatty acid can directly enter into your blood capillaries, right? Blood capillaries directly into your blood. While for the long, they cannot directly enter into your blood capillaries. So you guys remember chylomicrons. We'll be discussing chylomicrons in our biochemistry section, right? So chylomicrons are going to be the transporters. They'll be taking the long chain fatty acids and via lacteals. Do you remember what are lacteals? You guys remember the villi structure? We have a lacteals, right?
Yes.
Lacteals are basically the lymphatics, right? So the long chain fatty acids are like they'll just sit in a car, the chylomicron cars, and it would be taken by your lacteals, right? So the reabsorption is via your lymphatics. Is that clear? Hello? Hello?
And these
Yes,
lacteals,
Okay, so let me just give you an overview again. We have fat droplets. Bile is going to emulsify that, convert it to triglycerides. Lipase are going to convert triglyceride into fatty acids. Fatty acids can be short or medium chain, long chain. Short and medium can directly enter your blood. Long chain are going to be transported via chylomicron into the chylomicron. Chylomicron will be taken into lacteals, right? Into your lymphatics. Okay, so let's discuss our last reabsorption, that are carbohydrates, right? Carbohydrates. How do carbohydrates get reabsorbed, right? So carbohydrates, they can be monosaccharides and they can be like polysaccharides, right? So the monosaccharides are basically, like for example, your glucose, your galactose, like the monosaccharides, right? Monosaccharides, for example, your glucose plus galactose, they are going to be reabsorbed via transporter. What is the name of that transporter? Yes,
Sodium transporter 5.
SGLT1 transporter. That again is Na dependent transporter, right? While the fructose only is going to be reabsorbed via GLUT or GLUT5. We discussed that in our endocrine section. If you guys remember, you have a table in the first aid, right? That's clearly mentioned here, right? Okay. So this was all about intestinal reabsorption. So the last topic which we'll be discussing is electrolytes, right? So it's going to be a small topic, a small overview, and with that we have finished our physiology section. Tomorrow we are going to start our pathology, right? So I will be okay. Yesterday I was expecting you guys to be there in the Discord, and there were very little participants. Why? No? Hello? Are you guys going to join it
We
today?
didn't get it, the link of
Okay.
Discord.
You didn't get the link of Discord? Okay, please text Dr. Hamza for that. Okay, so today, again, you guys are going to have 1 hour of break and I'll be there in the Discord. Please join your Discord. Please continue your sessions. Okay, I'll be waiting today, okay? Yesterday, I was also waiting for quite a long time, but there were very less participants. So for today, it's a humble request, please. Just join the Discord server right after your class, right?
Okay.
Okay, thank you so much. So let's discuss our electrolyte, right? So let's discuss our gastric or parietal cells. So as we discussed that the gastric or parietal cells are basically going to, like release H plus, right? H plus. We know the stimulus, for example, 3 stimulus, gastrin, histamine, vagal stimulation, acetylcholine is going to help release your H plus. Remember, again, we have carbonic anhydrase, if you guys remember, right? We already know this enzyme now because we have discussed it a lot of time. So basically, the carbonic anhydrase, what's the function? Is going to convert is going to join the H2O and CO2 into your H2CO3, which is in turn going to be converted into H plus and bicarbonate, right? So again, we have a pump, which is basically your ATPase pump, sodium and that is your H plus and K plus pump, hydrogen potassium pump. So the main idea which I want to discuss here, with every release of H plus, 1 HCO3 is reabsorbed in your blood. Remember that, right? As we discussed it a lot of time in our renal sections, but keep that in mind, right? So this is basically known as postprandial alkaline tide effect, right? What do we mean by postprandial alkaline tide effect? Whenever we consume food, we are going to have release of H plus. But with every H plus, 1 HCO3 bicarbonate is going to be reabsorbed in the blood. Is that clear?
Yes.
Hello? And this effect is basically known as postprandial alkaline tide effect. Is that clear? So with this, we have finished our physiology section. Hope so you guys enjoyed, and I'll be waiting right after 1 hour. You guys can take 1 hour of break. I'll be waiting there in the Discord server. Please be there on time. And thank you so much. Tomorrow onwards, we are going to start pathology, and pathology is going to be really interesting, right? Believe me. And we are going to wind it up within 3 days, and so get ready for that as well. And soon we are also going to have like NBME, like in the group which we made. Dr. Hamza already mentioned there the timing. He'll be mentioning that as well. So those who are about to give their exam, like within a month or 1.5 months, so please do attend that NBME. Right after that, we'll be separating your task. And Dr. Maheen is going to join from Monday. She's like nowadays she was doing some works for her match, getting vaccine done and things like that. So that's why she was busy. And thank you so much, and have a nice day. See you tomorrow.
Thanks, Doctor.
Thank you.